Obesity and eating disorders. In this lesson, we will learn about the nature, causes, management of obesity and the most common eating disorders in adolescents and the related prevention strategies. The body is constantly changing between infancy and adulthood. Height and weight increase rapidly during the first few years and growth becomes more gradual across middle childhood. In early adolescence, there is a rapid growth spurt when height and weight again increase rapidly. Body proportions also change because various body parts grow at different rates. Skeletal and muscular development parallel the changes occurring in height and weight. Bones become longer and thicker and gradually harden, completing their growth and development by late teens. Muscles increase in density and size, particularly during the growth spurt of early adolescence. Physical growth is quite uneven or asynchronous. The brain, the reproductive system, and the lymph tissues mature at different rates. There are sizable individual and cultural variations in physical growth and development. Adolescents who are maturing physically and sexually not only come to feel differently about themselves, but come to be viewed and treated differently by other people. Lawrence Steinberg, a researcher, reports that around age 11 to 13, when pubertal changes are peaking, European American adolescents become more independent and feel less close with their parents, with whom they often argue. Hormonal changes in early adolescence may contribute to these conflicts as well as to moodiness and bouts of depression, bouts of restlessness as well. However, none of these experiences is inevitable. Parents can help the children successfully adjust to this transition phase by maintaining close relationships, being patient, and helping adolescents to accept themselves and the physical and social changes they are experiencing. Clearly, the early teen years are a period when biological changes transact with changes in the social environment to influence how adolescence is experienced. Dietary excess or eating too much is yet another form of poor nutrition which is increasing in Western and Asian societies and can have several long-term consequences. The most immediate effect of overnutrition is that children may become obese and face added risk of diabetes, high blood pressure, and heart, liver, or kidney disease. Obese children may also find it difficult to make friends with peers who may engage in name-calling. Indeed, obese children are often among the least popular students in grade school norms. Such adolescents are much more likely than their thinner peers to be obese in later adolescence and adulthood. Heredity definitely contributes to these trends, yet a genetic predisposition does not guarantee obesity. Highest levels of obesity are found among children who eat a high-fat diet and then don't get sufficient exercise to burn these calories they have consumed. Marasmus, a growth-retarding disease, affects infants who receive insufficient protein and too less calories. Kwashiorkor, a growth-retarding disease affecting children who receive enough calories but little of any protein. Vitamin and mineral deficiency, a form of malnutrition in which the diet provides insufficient protein and calories but is lacking in one or more substance that promotes normal growth. Iron deficiency or anemia and listlessness caused by too little iron in the diet that makes children inattentive and may retard physical and intellectual development in childhood. Obesity. Obese is a medical term describing individuals who are at least 20% above the ideal weight for their height, age, and sex. They grow up with an accelerated growth in which children have experienced growth deficits, grow up very rapidly to catch up to the growth trajectory, and they are genetically programmed to follow. Bad eating habits that can lead to obesity are often established early in life. Some parents use food to reinforce desirable behaviors. Example, clean your room and you can have some ice cream. Or they can bribe their children to eat foods they don't want. No sweets until you eat your vegetables. Unfortunately, children may attach special significance in eating that extends far beyond its role in reducing hunger if they are encouraged to view food as a reward. Moreover, use of high-fat, oily, junk, greasy snacks and food bought or ordered from outside as a reward may convince young ones that the healthier foods are less tasty. In addition to their poor eating habits, obese children are less active than normal weight peers. Of course, their inactivity may both contribute to obesity, and obese children will burn few calories, and this will be a consequence of their overweight condition. One strong clue that activity restriction contributes to obesity is that the amount of time children spend in sedentary activity of watching television is one of the best predictors of future obesity. Television may also promote poor eating habits. Not only do children tend to snack while passively watching TV, but the foods they see advertised are mostly high-calorie products containing lots of fat and sugar and few beneficial nutrients. Heavy TV viewing can also contribute in subtle ways to undermining children's health and well-being. You have probably heard that most adolescents are becoming obese, but obesity is a clear threat to physical health, having been implicated as a major contributor to heart disease, high blood pressure and diabetes, and rates of obesity have been increasing among all age groups and especially the young children. There are many contributors to obesity, with hereditary predispositions and poor eating habits being most heavily cited. However, it is also true that many people are obese because they don't get sufficient exercise to burn these calories they've consumed. Unfortunately, TV viewing is an inherently sedentary activity that is less likely to assist children to burn excess calories than physically active play or even performing household chores. Interestingly, one of the strongest predictors of future obesity is the amount of time children spend watching television. And adolescents who watch more than 4 to 5 hours a day are at most risk of becoming obese. The online schooling during the pandemic has added to the trouble. Let us now discuss about adolescent body image and unhealthy weight control strategies. So during adolescence, the bodies of boys and girls begin to mature into those of men and women, and for teenagers, feelings about this process and this end product become a very important part of identity development. A teenager who has positive feelings about his or her body, particularly about the appearance of that body, is more likely to have high self-esteem and have positive peer relationships. A teenager who is dissatisfied with his or her body and who focuses on shortcomings in comparison to unrealistic cultural and social ideals of attractiveness is less likely to experience depression and engage in unhealthy weight control behaviors. Body image dissatisfaction is the discrepancy between a teen's assessment of his or her physical appearance and that teen's internal picture of the ideal body. It has emerged as a strong predictor of teenage depression and one of the most important predictors of eating disorders and exercise dependence, and also steroid use among the older teens who exercise. It is important to note that the two measurements from which body image dissatisfaction is determined are subjective. Both body image, or what the teenager thinks he or she looks like, and the ideal body image, or a teenager's conceptualization of the perfect body, are derived largely from what a teenager believes about appearance and its importance in his or her life. Among adolescents, the prevalence and nature of body image dissatisfaction differs from the two sexes, as do the weight control strategies teens use in their attempts to modify their non-ideal bodies. Boys who express dissatisfaction with their bodies tend to fall into two groups, and those who wish to lose weight and those who wish to become larger and muscular. Is boys' dissatisfaction increases as weight increases only among those who weigh more than the average. Among boys who weigh less than the average, body image dissatisfaction increases as weight decreases. Boys of average weight express little body image dissatisfaction. In comparison, adolescent girls are more unified in their goals. As a whole, they feel compelled to be thin. For girls, as weight increases, body image dissatisfaction also increases. Unlike the boys, it is very few adolescent girls who express satisfaction with their bodies, according to research. Among adolescent groups and adult groups, it is found to be predominant for women that is considered to be a normative component of their living within the modern society. In general, the weight control strategies selected by teens correspond to the kinds of body image dissatisfaction that they experience. Girls diet to become thin and to reduce weight. For most part, boys choose strategies that they believe will increase muscle mass, and they exercise and participate in sports and take dietary supplements. Heavier boys are also likely to diet in order to lose fat, but not necessarily to lose weight as girls do. In addition to the adverse emotional consequences associated with body image dissatisfaction, engaging in extreme methods of weight control may compromise healthy development of an adolescent's body. The adolescent growth period is critical to the achievement of normal adult stature and reproductive capability, and the most obvious of the physical consequences of unhealthy weight control are those concerned with nutrition and growth. Adolescent girls who continuously diet are especially at risk. They consume significantly less fruits, vegetables and grains than girls who do not diet, and their intakes of calcium, iron, vitamins and zinc are also lower. And on the other hand, boys who diet tend to consume higher quantities of fruit than boys who don't. And for those adolescents who progress beyond simple dieting to the development of eating disorders, the consequences of unhealthy weight control involve much more than simple nutrition. Eating disorders that befall adolescents, anorexia nervosa, binge nervosa, and less extreme but serious manifestations of the symptoms comprising anorexia and bulimia. Teenagers with these issues are obsessively concerned about weight gain or weight loss. They are quite persistent in their denial of the peril of maintaining such extremely low body weight, especially in anorexia. Adolescents with bulimia engage in binge eating, and they consume large amounts of food in short period of time, and they follow these binges with behavior designed to prevent weight gain, such as vomiting, overzealous exercise or laxative ingestion. Adolescents engaging in anorexic behavior often appear thin, and this is a life-threatening eating disorder characterized by self-starvation and a compulsive fear of becoming fat. Bulimia, which is another life-threatening disease or a disorder, is characterized by recurrent eating binges followed by purging activities, the use of heavy laxatives or vomitings. Consequently, in the general population of adolescents, bulimia is much harder to diagnose than anorexia. Both anorexia and bulimia occur more frequently among girls and women than in boys. However, the prevalence of eating disorders among males may be underestimated because of the perception that eating disorders are a feminine malady. In most cases, eating disorder behavior is secretive, and adolescent boys who view such behaviors as characteristic of girls may be even more motivated to hide their symptoms. Eating disorders usually first occurs between ages 12 and 26, with a peak between ages 14 and 18. However, pre-adolescents and children from 3 to 10 years old have been known to exhibit symptoms suggesting that the foundation for a fully developed anorexia and bulimia may be laid at a very young age. Unfortunately, for most individuals, the morbid fear of obesity and unhealthy weight control behaviors associated with eating disorders are persistent and may continue into adulthood, but the majority of the adolescents diagnosed with eating disorders do not retain symptoms this long. As adults, however, they are at a risk for other psychiatric disorders, especially those involving depression and anxiety. Physical consequences associated with the development of bulimia include damage to the esophageal tube and tooth enamel erosion due to induced vomiting, as well as the development of obesity. Although obesity in children is only a moderate predictor of obesity in adulthood, obesity during adolescence more strongly predicts adult obesity. Therefore, bulimia in adolescents may place individuals at a risk for many obesity-related health issues later in life, such as heart attack, stroke, and even death. Fortunately, death rates associated with anorexia have fallen. However, physical consequences of the starvation associated with anorexia are numerous. Both thyroid and cardiac function may be compromised and structural damage may occur. Anorexics may experience constipation, and bone density scans of girls who starve themselves reveal levels of calcium that are far below normal. During adolescence, at least half an hour of individual's adult bone mass is laid down, with peak adult bone mass occurring during young adulthood. Anorexic behaviors prevent the intake of sufficient calcium and minerals to complete this process, and girls with extremely low body weights also experience amenorrhea, which is the cessation of menstrual cycles. Because estrogen and other reproductive hormones regulate the rate of material turnover in the bones, amenorrhea also adversely affects bone density. Thus, whereas both anorexic boys and girls may fail to lay down calcium, anorexic girls also experience bone loss due to the hormonal effects of amenorrhea. With the restoration of adequate consumption of nutrients and the resulting weight gain, cardiac and thyroid function return to normal as long as there has been no permanent damage to the heart muscles. Target weights based on population norms for age and height are often too low for many girls. With increased intake of nutrients, the bones once again begin to lay down calcium, but even so, individuals diagnosed with anorexia have an increased incidence of fractures and are at a risk for the early development of osteoporosis. A host of factors related to the family appear to influence eating and weight control behaviors for all teens. A chaotic or tumultuous home environment may place adolescents at a risk of developing eating disorders, as does recent experience with a family-related loss, such as the death of loved family member, and both levels of conflict and low levels of emotional responsiveness among family members are associated with adolescent bulimia. And on any day within such families, an adolescent's bulimic episodes appear to be catalyzed by family hassles and conflict that the teenager experienced earlier that day. Teens with a family history of eating disorders and those coming from families in which appearance and body image are emphasized are also likely to use unhealthy weight control strategies and to develop full-blown eating disorders. Another family factor that seems to be related strongly to teen body image dissatisfaction and weight behavior problems is the feeling of being unloved by one or both parents. Intrapersonal factors that influence body image dissatisfaction and the development of unhealthy weight control strategies among teens are both emotional and behavioral. Emotional factors include a tendency on the part of the adolescent to internalize stress, intense emotions, and feelings. And bulimic girls seem to have a particularly difficult time with the outward expression of emotion. In one study, girls with bulimia were more reluctant to express feelings than girls who were depressed or had a history of psychological problems but did not have eating disorders. The bulimic girls also took longer to retrieve emotional information and had trouble identifying their own moods. Behavioral factors that appear to have the most influence on eating and weight control strategies among adolescents are participation in certain sports and dieting. Participation in sports that have a weight requirement, such as wrestling, swimming, rowing, or sports in which thinness is an advantage, such as running or cycling, has been associated with disordered eating and excessive exercise, as well as the use of steroid and food supplements. Dieting places teens at the risk for both the development of serious eating disorders and obesity. Perfectionist behavior has also been associated with eating disorders in adolescents. The treatments for adolescents with high body image dissatisfaction and those who employ unhealthy weight control strategies include a variety of approaches, but the most effective involve the family of the adolescent. For instance, many studies point to the fact that outcome improves when an adolescent is treated with an outpatient basis with high familial involvement. Parent education and family support groups are also beneficial, and in fact a study of teenagers who were able to recover from their eating disorders without professional treatment revealed that the earlier teens' parents are intervened, the shorter the duration of the disorder and the more complete the teen's recovery. Thus, it has become very apparent that the parents and family of teenagers can be instrumental in the prevention and treatment of eating disorders, even though no single specific pattern of family dysfunction has been associated with their development. Programs and therapists who focus on the strengths of individual families and tailor treatment to support these strengths may be more effective than more generalized approaches to family involvement. Studies related to individual treatment issues have produced interesting results. When adolescent girls sent for bone density scans found themselves to be the only young person in a waiting room filled with elderly women, they experienced an acute awareness of the physical damage caused by their anorexic behaviors. This suggests that the novel ways of altering the perspectives of anorexic adolescents may assist them in forming more realistic views of the consequences of their actions. In another study, having noted that boys are raised to focus upon the instrumental capabilities of their bodies, what they can do, and girls the ornamental aspects, how they look. So researchers had adolescent girls who had been diagnosed with eating disorders complete an assessment that included standardized questions about appearance, along with questions about the instrumental aspects of body image. The girls were surprised to find themselves considering how their bodies worked for them. The girls also discovered that many of the anorexic symptoms, such as bloating and headaches, reinforced negative associations about their body function. Finding ways to incorporate body competence and healthy functioning into the general definition of body image or body concept is beneficial for girls. Other research points out to the preventive measures that can be directed toward all adolescents. For example, and this one being very interesting, family meals associated with higher self-esteem among teenagers, and high self-esteem is possibly the single most protective factor against body image dissatisfaction. Therefore, frequent structured family meals during which the atmosphere is positive may prevent the development of unhealthy weight control behaviors among teens. In fact, adolescent girls who participated in 3 to 4 family meals per week were 1/3 less likely to exhibit unhealthy weight control behaviors than the other girls who participated in family meals less frequently. Other research suggests that creating environments at both the familial and school level that emphasize health and fitness rather than appearance is also likely to increase body image satisfaction. Summary of this lesson. Body image is an important aspect of adolescent identity development that influences a teen's emotional as well as physical health. Expanding the concept of body image beyond the male and female appearance ideals promoted by the popular cultures of industrialized nations and promoting high self-esteem may inoculate teens against body image dissatisfaction, therefore preventing the development of self-destructive weight control strategies that often lead to diagnosis of serious eating disorders such as anorexia and bulimia.